The three general surgery employment models, and what each one means for your contract leverage before you sign. Before you evaluate a single compensation number in a general surgery contract, you need to identify which of three structural models you are entering. The model determines who controls the operating room schedule, how your production is measured, and how much leverage you will have when you renegotiate in year 3. Model 1, the hospital employed practice. This is the most common structure for new general surgeons entering the workforce. The hospital or health system owns the practice, employs you directly, and absorbs the operating subsidy that general surgery generates. Compensation is typically base-heavy with a productivity layer. The 2025 National General Surgery data shows that median base salary represents approximately 82% of total compensation at the median, with productivity accounting for about 7%. The hospital subsidizes the practice because surgical cases generate significant downstream revenue: operating room facility fees, anesthesia revenue, post-surgical hospital stays, intensive care unit utilization, imaging, and specialist consultations. That downstream revenue does not appear in your contract. The subsidy that keeps your operating room time funded does not appear either. Model 2, the independent or physician-owned surgical group. These practices operate outside a hospital system, often in partnership with an ambulatory surgery center. Compensation is more production-linked. A meaningful percentage of general surgeons in independent groups operate on contracts where base salary is a minority of total compensation. Production drives the number. These practices cannot absorb operating losses from a system balance sheet. Case volume, payer mix, and facility efficiency determine income directly. The trade-off is exposure. If the surgical volume drops, the revenue drops with it. Model 3, the academic medical center. The 2025 National General Surgery data shows academic general surgery pays $372,976 at the median, a gap of $129,971 below the community incumbent median of $502,947. That 26% discount is the structural cost of protected research time, resident supervision obligations, and teaching responsibilities. The P25 for academic general surgery reaches as low as $168,427, reflecting surgeon scientists with heavy research allocations and minimal clinical production. The P75 at $474,326 shows that high-volume academic surgical centers pay near community rates for surgeons who carry full clinical loads. Now the single question. When you receive an offer, ask, who controls the operating room block time, and who absorbs the cost if the cases do not fill? If the answer is the hospital system, you are in Model 1, and the downstream revenue argument gives you leverage. If the answer is the surgical group and the ambulatory surgery center, you are in Model 2, and case volume, payer mix, and facility efficiency are your leverage. If the answer is the medical school and the department chair, you are in Model 3, and the comp ceiling is shaped by research allocation, teaching duty, and departmental funding structure. The compensation number in the offer letter is real. The structure that determines whether that number can grow is the answer to that one question. Run your contract through ClauseLine at ClauseLine.com.